Hi, this is Dr. Susan Blakeman again, and today we'll be talking about diagnostic formulation. This is meant to be a fairly quick overview of this concept that will be reviewed and repeated across your curriculum. So the objectives are that we want you to understand what the purpose of the diagnostic formulation is, as well as describing components of a biopsychosocial diagnostic formulation. So the purpose of diagnostic formulation is to synthesize both the subjective and objective data that you have collected regarding your patient in a concise way. This is really a summary, an integration. It's not just a list of the things that you have collected. From this synthesis, you are going to develop a well-reasoned depiction of the patient's clinical status and needs. And to do this, you're going to build this using a theoretical framework. We'll talk a little bit more about that. When you have a good diagnostic formulation, when you have thought about what it is that is contributing to the client's clinical picture and what the client needs are, this is the way to communicate those impressions and your rationale for your plan. The diagnostic formulation really is what builds from the data you've collected into what you are going to do to best serve that patient. So at the bottom it says, in other words, formulation should reflect your thinking about the data you collect across all of the evaluation domains and directly relate to your clinical diagnoses and decision making. This is not a free-for-all. This is you being the expert clinician and saying, based on all of this, this is what is happening and this is what we need to do. So there are a number of strategies, and there are different types of biopsychosocial, or different types of formulation that you will find in your readings and in your textbooks and in clinical practice. But what we are going to focus on today is a biopsychosocial approach. This tends to be very familiar to nurses. You tend to think holistically and across many domains, and you really are trying to get a sense of what is happening for an individual. So this is from the Ross readings. Here is the link. This is available in the public domain. And you're going to, this is a way of categorizing your thinking. So what's happening across the social context over time, psychological context, and the biological context. The biological context includes physiological concerns that are influencing the mental status or the mental health presentation. So you want to be thinking about any illnesses. You want to be looking at lab values and vital signs. What is the stage of development? Does that have anything to do with it? Is there a teenager spending more time in his room and mom thinks it's depression, but it's really just separation and appropriate for the age? You want to be thinking about nutrition and hydration. You know, those are important physiological parameters. People cannot think clearly if they're undernourished. They may have cognitive difficulties and electrolyte balances. You want to think about sleep and substance or medication use or misuse that's contributing to the clinical picture. And obviously you want to be thinking about genetics. So common physiological influences that can affect your diagnoses, and these are things that you are familiar with already, either high or low thyroid function, intoxication, fever, pain, your blood pressure. You know, it's really hard to look like you're functioning well when your blood pressure is really low, for example. Nutritional metabolic imbalance and other things. In the psychological sphere, you want to be really going back to the diagnostic and statistical manual and looking at the criteria for each of the diagnoses that you are considering. In your formulation, you want to spell out based on the data I've collected, the patient meets the criteria for, list what those are, and and that will lead you to your diagnosis that you list. You can also say, based on what I've collected, they don't meet criteria for. These are the things that are ruled out. Or part of your formulation is, it looks like this person might have this diagnosis, but I need to have more data. And the getting of the more data is what you put in your plan. Okay? And you want to be clear about what is happening at what particular time. A time frame is very important, and you need to be making sure that you are meeting those criteria that are outlined in the DSM. It may be that somebody's looking like they have depressive symptoms, but they've only been presenting with them for a week and not 2 weeks, or not longer, which would be required for various diagnoses. You want to be thinking about the psychiatric history. Well, because they've had this before, it looks like this again. Family history. What are defense mechanisms and coping looking like? So that is pulling in some psychodynamic theory. This might be helping to explain why these behaviors are happening. We might have this overlying illness or diagnosis, and this is what's is manifesting in this types of behavior. Development, again, we talked about. So development will have impact biologically, psychologically, and socially, as well as cognitive functioning. What are those types of things that are contributing to this picture? Is there some perhaps delirium, which would be along the biological range, or is there a limit in the cognitive ability for a variety of reasons? Okay. Social, so this is really putting together all the interpersonal and environmental factors that can influence the clinical picture. So have the person lost their support system? Are there major stresses or losses or changes that are happening? What are the cultural implications that can lead to how one understands their mental illness or issues, or how they express them, or how their family or their community is allowing the expression of symptoms or experience of stressors and losses. Spirituality, where does that have to play? What is daily work life or school life like? How much are these affected, and how is that playing into this diagnostic picture as well as your plan? You want to consider that. There was a major disruption at work, and this caused some anxiety, and this caused this, and this is why we're seeing this today. Again, I told you development would come across all of the components of a formulation, and there are many other things to be thinking about. So this is a quote from a 2008 article that you were given to read as well. So I'm not going to go over that, but it's developed from summation and integration. Again, knowledge that is acquired by the assessment process and interpreted. Okay, so you are pulling it together using a framework. The interpretation requires a theoretical basis that might reflect a particular psychotherapeutic approach or a theoretically coherent blending of approaches. Okay, so if you're thinking, for example, along a developmental theory, then you want to be thinking, how does that make sense with what I am going to propose that we do for this client? And so using that framework, there's assumptions, values, and beliefs by which the nurse bases the care. And all these things are going to hang together. Your assessment is cohesive. Your planning is cohesive. How you understand if the client is getting better or doing worse, all is related to this process of pulling information together, synthesizing and interpreting it. Okay. There are many ways to interpret a situation, but when you use the theory, the point is how relevant is it and how explanatory can it be. So these are things that you're going to want to be thinking about in terms of theoretical frameworks. Okay, the biopsychosocial is one way that you can sort of map out all the different components, but there obviously are cognitive ones. If you think about learning theory or Piaget, for example, in terms of how people are functioning cognitively, particularly in early life. There are behavioral theories, so are there antecedents and consequences. You know, what is reinforcing the behavior? What do you think would be helpful in reducing or eliminating the behavior? Interpersonal theories, so thinking about relationships and the management of anxiety. What is happening for that person, and how does that explain where the symptoms are occurring and what we are going to do for them? Psychodynamic theory, so drawing on those internal conflicts, the defense mechanisms, coping, and of course developmental. And you can draw from some different theories, but you need to be cohesive in terms of how you're going to approach the problem. And if you are using a theory that's not biopsychosocial, but you want to be prescribing medications, if that's part of the problem, then somehow you have to pull in that biological piece as well. Okay, considering the 4 Ps, so you want to think about what is predisposing a client to these symptoms. So is there a genetic predisposition? Was there trauma early in life that's coming up? Is there a family situation that's been at play for a while? And then what's precipitating the event? So did something happen? Was there a stressor that occurred? What is causing this expression at this time? Perpetuating, what is continuing the symptoms for the client, and then also what is protective. You really need to be thinking in your formulation, what are the strengths of the patient? What is going to help them be able to engage in the plan that you are proposing and offer that prognosis? So, you know, how are you going to reevaluate progress? Okay, so here's an example, again, using that grid that we saw earlier, again, drawing from this work by Ross and colleagues. So across the social grid, what happened in the past, he had some dependence on his mother, then his wife left. Then right now he's got some supportive family and friends. He has successful employment, and he's dealing with the separation. In the future, what might be something that you can think about that would be helpful or in terms of moving the person along this domain? Psychological, you know, what are the personality traits of the person? And then, you know, how did these things contribute to his development of personality? And then where is he now in his psychiatric symptoms in relationship to these other stressors? And so therapy might be important. And biologically, okay, so there's a genetic risk, okay, so these are also the past things, these might be the predisposing things, and then there might be some precipitating things in there, as well as some perpetuating things. And then we want to think about what will be protective. Okay, so you have genetic risk, you have hypothyroidism, you want to rule out which is happening here. These are the biological functions that are disturbed, and then what will be something that is going to be effective. And this looks like he's prescribed a thyroid agent. Okay, so the trick in here is that you want to be both thorough and concise. Okay, you want to think about this. And the problem in clinical practice is that you don't often see formulations, particularly in an electronic record. There's not a space for it. But that doesn't mean that clinicians are not doing the thinking. It's just not something that's seen as it used to be. But you really want to be using what the patient tells you, using your keen observation skills, using what you collect from your examination, albeit your mental status examination as well as any physical examination that's required. Pulling in data from other sources, from the medical record, from the collateral, and picking who is the important person. If it's a child, you want to be looking to the parents or the caregivers. You might need data from school. From an adult, you might need data from whoever the support person is, the significant other, the coworker if you have permission, whatever is going to help you really fill out the picture, and many other options for really collecting the data that you require. If you don't have all the data, and you might not be able to get that collateral, you might be waiting for a lab value to come back, or the patient might be too distressed for you to ask all the questions at once. You want to put that in your formulation. I can't rule this in or out until I know this, and then this is what I'm going to do about that. So your diagnoses will be provisional. They'll be rule-out diagnoses, and your plan will be what you need to do to collect the rest of the information. So this is what we have talked about so far. If you have other thoughts and questions, you know how to get a hold of me. And we talked a little bit about, whether or not you see formulation in practice and whether or not you see it documented, but ask your clinical preceptors, ask the people that you're working with, how are you thinking through your case? How did you arrive at this diagnosis and plan? What points to this? And as you're reading notes, try to do your own detective work. You will get plenty of opportunities to practice as we move through your curriculum. But thank you so much for your attention, and we'll look forward to revisiting this.